Biliary complications of laparoscopic cholecystectomy are commonly reported as early, and they are represented by cystic duct leak, gallbladder bed leak, stenosis by cleft, bile duct leak, and bile duct transection. Late complications are mainly represented by chronic biliary stricture. Most frequently, traction maneuvers on the gallbladder determine a shift to the right of the axis of the bile ducts, so modifying the configuration of the Calot's triangle. This explains the high incidence of biliary complications following lap chole, in the range of 3 to 6%. A clip may fall, leading to cystic duct leak. Use of cautery may cause inadvertent damage of the right or the left hepatic ducts. Moreover, thermal damage may be transmitted to the surrounding structures, so causing late cicatricial stenosis. Sometimes, a clip is mistakenly applied on the CBD and the cystic duct is cut below the proximal clip. But the most dramatic disaster in the course of lap chole occurs when the CBD is confused with the cystic duct and transected. The same happened with the hepatic duct. Clips may or may not have been applied on the transected edges of the bile ducts. ERCP allows for accurate assessment and treatment of biliary complications. Leaks are managed by endoscopic sphincterotomy, nasiobiliary drainage, or stent. Stenosis, early and late, are treated by dilation and stenting. Finally, transections have been treated at our department by an original combined endoscopic radiologic approach. In this case, a jaundiced patient underwent ERCP 3 days following lap chole. A complete stop is identified, leading to subsequent percutaneous radiologic cholangiography, which confirms the complete transection of the common bile duct. In our technique, a guide wire is endoscopically inserted into the distal CBD. Simultaneously, a hook is radiologically advanced to meet with the endoscopic guide wire. Once the latter has been caught, it is withdrawn through the skin, allowing for radiologic positioning of a biliary prosthesis. In this radiologic sequence, the duodenoscope is in place while the interventional radiologist is trying to retrieve the endoscopic guide wire by means of a hook. Injection of a contrast medium well demonstrates the site of bile leak and helps orientation of the two metallic wires. The guide wire has finally been hooked and slowly pulled outside by the radiologist. At this point, the endoscope is carefully withdrawn. A dilator is percutaneously advanced onto the guide wire through the defect, leading to positioning of a radiologic internal-external stent. At 1 month, radiologic control of the prosthesis shows no leaks. The drainage is converted to internal stent. 6 months later, the patient is in satisfactory conditions. Failures of preliminary joint radiologic endoscopic approach are managed by surgery, as shown in this case. To date, 3 successful radiologic endoscopic rendezvous have been completed out of 5 biliary tract transections referred to our center.